David wrote a book in 1990 called Mobilisation of the Nervous System, and he's done a second book called Sensitive Nervous System, which was published in 2000. The Butterworth 1990 book has a lot of pictures of the nerves, but basically what happened is, traditionally the nervous system's been taught and understood as how nerves work, and looked at what the nerves do and don't do, but not really thought about as a mechanical structure. And Maitland was the first guy to look at the slump test, looking at the gross nervous system and the cord. And then Elvey from Western Australia started looking at upper limb tension 1 and 2. And then Butler and Shacklock started to look at a lot more, and then they developed that they can use nerves or mechanical structures which are innervated and can be a source of pain or noxious sensation under abnormal mechanical pressure and abnormal neural mechanics, and look how the nerves work in the body. And they were the first ones using cadavers initially, showing how nerves do move and work. And there's a classic picture of the Butler's sensitive nervous system and the mobilisation of the nervous system, as to how the nerve has different tethering points. We're discovering about where nerves get caught today with my group earlier on. And at C6 and T6 and L4, there's tethering points where the nervous system moves away from or towards those points. And there's also one in the back of the knee. There's other catch points as the nerves run through the glutes and through the genitofemoral nerve through the psoas, and then underneath the inguinal ligament around the head of fibula, and also the retinaculum in the wrist. So they were the first ones to look at nerves as being a mechanical issue, and they took that as far as they sort of could in the 90s. Purely mechanical, and they still teach mobilisation of the nervous system to move the nerves, and they started getting into the pain science and looking at how pain actually works. And then I remember doing my postgraduate work in '87, and we had, for modern manual therapy, a 30-page article written by Jenny Watson, one of the lecturers we had at Cumberland, on pain. We had to memorise that pretty much for our assessments and how pain worked. And nociceptor fibres, C fibres, and messages went to the brain, and it was pain going to the brain. And Butler and those guys first looked at that and worked out that it wasn't actually pain messages. The body doesn't produce pain messages.
Hello.
What actually happens is that each nerve ending can produce receptors, and those 3 receptors are chemo, baro, and thermoreceptors. So temperature, pressure, and chemical. Then those receptors can be laid down in more or less numbers according to the person's situation. They're plastic. It's not a set number. And then those messages, it picks up changes in pressure, temperature, or chemical activity, such as if you have a tissue injury, where you sprain a ligament, for example, and tear cells, and the cells leaks out into the tissue, which then sets off the inflammatory reaction. So the mediators of bradykinin, substance P, prostaglandin, histamine, and oxytocin start to have a bit of a chemical party and set off reactions, which then the nerve endings pick up increasing these chemicals, these inflammatory mediators, and that starts off the body's reaction to send in the macrophages and the leukocytes to chew up the damaged tissue and lay down and repair the new tissue. So that's the normal basic process. And when there's a change in that, the body picks up the extra chemical activity, then the body says, well, something's gone wrong. We better tell the brain something's wrong down here in the ankle, let's mention, and that comes through as pain. And that pain is in context, so that it's very from individual to individual. And so the first one looking for pain from that perspective as being an interpretation of messages being sent up, changes in those things, and it's all about the context that the messages are turned up in. So if you're a farmer or a labourer and you hit your thumb with a hammer, you sort of get that, and move on with it. But if you say an office worker and get a paper cut, you're off working in compo for 6 weeks. Yeah? So it depends on context. And we discussed this the other day with our group. And the Explained Pain book talks about that women after childbirth were thought to have a higher pain threshold. But what they're saying is women after childbirth probably have a more realistic pain threshold. They also note in the first article, in the first version of Explained Pain, that up to that date, all the pain science and research have been done on male animals by male researchers. So it's all about how the body interprets the pain. So Butler was really the first into moving to how the system works and how it moves. And then it's not just how the nervous system moves, but how the parts of the body, and they've taken the whole pain science into explained pain and to the neuromatrix and how other more advanced and chronic stuff works. And we know that the pain changes the chronic pain will change the activity in the brain and in the sensory homunculus, which is the bit that picks up your body parts. And they've shown that, like with the studies they've done where they put a tourniquet on the arm, when they put a tourniquet on the arm in the functional MRI, straight away the sensory part of the homunculus reads the arm, lights up. And they'll leave the tourniquet on for 20 minutes, the area of activity doubles in size. Now in the acute situation, that goes back to normal after a very short space of time. But in chronic pain, that actually increases, and then what happens is basically that part of the sensory homunculus is trying to interpret the messages, and it basically requires more RAM. So it decides to take over the other cells in the homunculus, and that adapts. And the other studies coming out over the years, and the last batch I got from 2012 conference shows that actually parts of the sensory have migrated or changed, or larger in size or smaller in size, in response to the chronic pain. So the brain has plastic changes, and they've always talked about, when I was at uni, you're born with the brain cells you're going to have for the rest of your life, and you destroy your brain cells, and you lose brain cells. But that's not the case. The brain cells you have at birth are not the same brain cells you have now. And there's a condition called Sanfilippo syndrome, which we've done some runs with and helped out with the fundraising over the last few years for these people. And kids are born missing an enzyme which allows the brain cells to regenerate and to renew. And they, most of them die of Alzheimer's and seizures. The lucky ones live to 20, but most of them don't live past 40, 50. So there is that. So our brains are changing all the time. It's plastic in response to that. When explained pain first came in, it's basically we were already doing the pelvic and thoracic stuff, and we knew it was working. We weren't too sure just how or why all the bits were working. We had explained some of it, but not all of it. And certainly when this came out, it filled a lot of holes in, a lot of holes. There's still a few little uncertainties, but generally speaking, we can now. That's why when we first did this stuff, we called it the pelvic routine and the thoracic spine treatment routine, but then we changed that to reflect what it really is, which is the global mobilisation and homuncular refreshment for the pelvic and thoracic complex. And that's what the starting point of the stuff is.
So what do you suspect the physiology behind the pelvis and thoracic is to pain signs?
What we're saying with when someone comes in with a problem, we've got to do the assessment, and we've got to sort of work out and say, go through the history and work out what's happened in their life. Apart from, first of all, where the problem is, where they're presenting, where the patterns are, what they're experiencing, what they're complaining of. And then once we map it all out, we have a pattern in front of us. And then we look at the history of what's happened, and they fell off a horse when I was 15, had a car accident at 21, difficult childbirth at 30, or something like that. So looking at incidences of trauma to the pelvic complex, and it can be a lot of force in a short period, like a car accident or falling on a banana skin, or a little bit of force over a long period, such as postural syndromes or school bag syndrome, handbag syndrome, or just carrying kids on hips when they're young and that sort of stuff, or traumatic childbirth, stuff like that. So what we're coming from the point is that the primary dysfunction is the dysfunction of the pelvis, primarily causing secondary maladaptations throughout the body's biomechanical system, not just musculoskeletal but also neural and mechanical. And then you get the altered function, the sensory smudging of the sensory homunculus. And that creates the dysfunction. So we're starting from a dysfunction hypothesis as opposed to the classical teaching of give it a label, give it like a diagnosis. And that diagnosis is driven by the drug companies. They give it a label, give it a pill. That's the paradigm that exists now. I'm challenging that paradigm by saying, no, let's start with the person comes in. We say that their problems are primary dysfunction, causing secondary maladaptive changes, shortening, tightening, or hypermobility, or just alters neural pathways so the muscles can't function properly. And also if the pelvis is really out of whack, the muscles can't work at the optimal mechanical advantage. And your pelvis is your biggest muscle attachment catchment. So if you address all that and get it all moving, then we're not only resetting the muscle, alter muscle spindles and stuff like that, and moving things around, but also the sensory input of you putting your hands on the patient actively involved in the treatment, not just being a passive dummy, and firing muscles. It's also flushing out the sensory homunculus and refreshing that sensory homunculus and resetting that that dysfunctional image.
Cool. Do we all understand what Nick's just said? There's some really good points there, because I think for the physios in the room, you know, there's a big movement away from manual therapy, which I think is insane, but we won't go down that path today. I understand some concepts around that, because the evidence base says that a lot of manual therapy is maybe temporary or doesn't have long-standing effect. But what I'll argue, as Nick said, is it's actually resetting the whole nervous system, really. You know, does everyone understand the concept of homuncular refreshment? Are we getting that now? So don't think that when you're doing a pelvic clearance or a thoracic clearance or anything that you're just working primarily at that segmental level. You're actually implementing change through the whole body. And then the challenge is to follow that up with effective advice, education, exercise therapy, things like that to help. But know that we've got to think bigger than just the muscle or the nerve. We've got to think a bit bigger picture.
That's the century. That's that bit around the Butler's book showing the effect like the smudging. That's what they talk about, that when your imaging is blurred by the dysfunction. So my argument about these guys saying manual therapy has a permanent effect, I know it doesn't have a permanent effect, but that we know we need to make sure we can change the situation, alter it by measuring, taking basic measurements, altering it, and then giving the patient stuff to do themselves. And I don't call them exercises, I call them self-remodeling strategies or thoracic reprogramming. On my exercise sheets, it's thoracic reprogramming and pelvic remodeling. And so it takes, Shirley Salmon's work shows that it takes 6 weeks of tissue cells to start showing permanent changes at the cell level, 100 microns for muscle cells, hair cells 120 microns, so that level, and 6 or 12 months for the whole gross tissue to remodel. That's what Shirley Salmon's shown well over the years. She's done my third course with her in 1998, the second course in 2005. So tissues can remodel. And I've spoken to people, doctors and even the head physiologist at head of the physiology department at Sydney University. I was treating her in 2000, talking about tissue remodeling. Here she is, the PhD, and she's in charge of writing the curriculum for the doctors, the vets, the nurses, and the dentists. And she didn't know that. And I pointed her to a conference that came out and presented at Cumberland College of Health Sciences, which is now Sydney Uni, in 1987, where I was at my postgrad year. Pulled out the proceedings and showed it to her, and showed her the relevant articles in the proceedings. And she looked at her and she went, "Oh shit, that's in my office. I better go back and do some rewriting." So I worked with that there, and I've had conferences where I've spoken at with people like Merv Cross and the top doctors in the room, our top specialists and physios, and I was sitting with the sports medicine specialist who was the director of our NSWIS, which is the New South Wales Institute of Sport. And during my talk, I spoke about how the disc flow of fluid overnight moved and your spine changes height over 24 hours, and all this sort of stuff is part of the thing we're looking at when we're doing with patients. And I was having lunch with him after a presentation, and he said, "Oh, that bit about the disc flowing over fluid," he said, "I never knew that." And he was directing NSWIS. So there's a lot of people out there who just miss the information and don't get it. And if you haven't come across this and brought all the other stuff together, you're missing out a lot of this stuff. And where this stuff is, it explains a lot of stuff, but it also means that you've got to actually embed this in your practice and understand how it works. And the patients are having their dealing with them. You're not just working from a physical perspective, but also the education and explaining how this stuff works. And then in some cases, I'll actually give them a copy of the download. They just read the books out, but they just kept disappearing. So now I have an electronic copy, which you guys have on your download.
So I think that's a perfect.
I have a question. Have you seen cases with patients that have like hyperalgesia and like allodynia and like extreme cases like that, where like pelvic and thoracic routines have helped change their like?
Yeah, have helped to change it. In some cases that we've helped them to a point. We haven't been able to, without some cases, some really severe cases like sympathetic involvement, we've had to go back to ganglion stellate blocks before we've actually achieved the final result or better result. But certainly we have had people come with that, and by doing that, that has made big changes. I'm talking about 15, 20 years of chronic pain.
Don't underestimate as well how those changes can make a difference. We don't pretend to say that we're going to fix everything. You know, it's never Nick's language as well. It's not mine. But don't underestimate what you can do.
Yeah.
Like we get the train wreck patients. Nick used to call them when he taught me Christmas light syndrome. Remember that? Yeah. You guys heard of that terminology? Where there's just bang, 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 bang. We had a client here the other day, just to let you know, just seriousness of down to as understanding pain science to get there. Can I ask you a question, Nick, then? Because you just said getting the clients to understand this is what's actually most important. Can you maybe talk through with us some of the strategies you used over the years to explain to your patients about, because your clientele compared to mine is much more chronic pain, as you know. What sort of language or what sort of analogies do you use that you find is really effective with your clientele?
First thing I used to express while you're out in the phone call, we talked about the receptors and how they can change in the body, and it's a mix of chemothermopressure receptors and the analogy of how the farmer can hit the thumb and not have a problem, but the office worker gets a paper cut and is often coughed over 6 weeks.
Yeah.
And it has all perception. But then we also have the charts that work with Dave Butler producers. We have this thought viruses. And thought viruses had this chart with all these little sayings. I was trying to put it on part of it. There's a chapter in here, number page 80 in this one here. I've just highlighted. I was doing that. And I show them this picture of the thought viruses. And it has things like, if man can put a rocket on the moon, why can't they fix my pain? Stuff like that. And there's a few examples of that in the thought virus.
So you can see how that page. Negative language is already, limiting your ability to heal.
So some of the things, pain, there must be something harmful happening today. We can put a man on the moon, why can't I fix their pain for me? I'm so frightened of my pain of injury, I'm back again and I'm not doing anything. And these are common things. And we show the patient, I say, look, do you recognise that? And they go, oh yeah, I recognise that. Oh, I said, 2 or 3 of those are, I can relate to. So I sort of show them, this is a mass-produced poster. This is what, this is what you've been going through. And he said, yeah, now, okay. Then I talk about this, then I show them the other one, next one I show them is the chart of this one, which I love. It's this map of where they've been, and it's things like Compo Railway, Re-Injury Centre, Mount Nowhere, Lake Avoidance. My favourite for a lot of my patients, the Sea of Endless Professionals. They've already been to, and there's all sorts of helpful, unhelpful. And I showed them that. So now you reckon I say some of those won't relate to you, particularly most of them are private patients, so that doesn't relate to them. But they'll look at that and they'll see a few places they recognise, and I'll just say, look, that's one of my favourites because they've already come to me after there have been 5 or 6 people or more. So I say, we're now here at this opportunity bypass, and we're going to get you back up here now. This is what's going to happen. This is where you've been. We're going to get you out of there and show you the way out, and sort of show you the light. And then they're getting them back into action, which is some people get back a bit too quickly. We had a lady last week we saw at Botany, who I didn't see again on Thursday because she decided that she didn't do the stretches we showed her, and the stuff we did, because she felt so good she went and did all the housework. And she got stuck into it again and didn't bother following through that. And once I saw her the second time, explained that to her, she was more compliant. But then we talk about getting them back into what I call graded exposure, where the
this is a very important concept.
Where their tolerance was like at the Everest beforehand, and after their injury, their tolerance is lowered, and they've got to learn how to gradually build that tolerance up, but over time. So not to go into like this lady did last week, get into it, stuck into it, and just got to start moving themselves first, and gradually try a few things, and gradually build up that and find their level. And I even have from a workshop with this stuff, I've got blank worksheets of these, which I have copied, which I then give them a blank one of these to let them sort of work out their own how much of what they want to do and what they want to do, and they can write out and work out their own level, and then let them know that I'm going to be there to help them with that. And then the third one is not, I can't find a copy of it here, but it's about taking control, about having them make sure that whoever's to read them has explained them properly what they've got, why it's got there, and also how they can take control and use these strategies we've given you, and understand, bearing in mind that we've already identified what's caused their problem is in the past and unlikely to be repeated, and then giving them and giving them the information and empowerment and the tools to move on and manage themselves. And that's what we sort of take this, and these are on. I meant to bring a copy of them up, but I've got the charts printed at home, both up there and the Hornsby Clinic. So with the visuals like that, the patient gets pretty much a much better idea of what's what's going on, what's it going to be, particularly the chronic ones. I don't use it on every patient, they don't need to, just a basic explanation can do it. But you're giving them some tools to work with, and you're helping them tailor those tools to suit themselves. As I said, doing this stuff when it works well, and also fails beautifully. So when it does fail, we can look at things like Ives' situation where there's a 180 centimetre tumour. That's not going to change with any physio, I know. Okay, and if there's a fracture or a stress fracture or a ruptured disc, you can't push the jam back in the donut, then it's not going to work. But you know that quickly that's not going to work, and you get them onto the right.
And Nick, how often do we see that? That tumour, it's the first time I've seen it in 8 years of being a practicing physio. So I think what Nick said, and especially, you know, to you, Denise, Rick, Savannah, Casey, when you're dealing every day with a lot of chronic pain patients, and sometimes we know how well the systems are. Nick showed you, don't forget about this stuff. Put it in the back of your head and think about how can we relay and educate, because I think, as Nick said, self-management is really, really important. And what's really good with your own clinical reasoning is, and for all of us here, is that if things aren't going quite right, we need to always think about why, which is what I challenge you to do, even straight away. Particularly in my younger days, I'd see a train wreck patient and just throw my hands up. We've had a few in the last week, and me and Meeks have been here, we just smile now because we know how to handle them. We had a lovely lady who came in with an acute neck injury who was really terrified and scared, but really we found out when we delved into her history, she had a big rheumatological arthritis, she has chronic pain, chronic history, and Nick, can I bring you in on this one, Nick? Some of your more sensitive patients you don't do as much with, because what happens when they, on the back end, when you push them too hard?
They react. You don't have to sort of pace the stuff, so when you're into them, you don't go in. That's why we do the assessment. You're going to go in easy or going to go in hard, and it's working out how you go in. As I talk about going in, some patients like the Irish mine detector. Seen the Irish mine detector?
The NRA days, eh? All right. And that's getting to know your client as well. So we understood straight away that we couldn't do as much of, I do it the same way. I want you guys to, but I want you two to now, let's see where we're at when you guys can exchange stories about how we do our own pelvic stuff, because ours has evolved a little bit, but I've learned everything I know from Nick. And interesting enough, with the pelvic stuff, I did 2 courses by the MET person. I'm not going to mention her name on the video, but as soon as I let Nick stuff, that was gone.
A lot of the versions of taught are just overcomplicated and very confusing. A lot of people have trouble picking up because it is complicated. Whereas we've blended and boiled some of the systems down to this, what you've got with the power of the pelvis stuff on the download with the upstep downstep system, and that's easiest to pick up. So it's a starting point. It's pick it, you get with it, and you build on it. But you don't just, it's not the tool. It's just where you start and you build on. Then as you go and do courses in it, then you can add more stuff to it from there.
So for you people particularly, Rick, you're almost done as well, aren't you? Are you almost graduating too? Another year. Yeah, third year. But to all the people about to graduate, Casey, over there, just remember that whatever you learn, we don't expect you to go back and practice the same way we practice. But we want to take what you've done on this internship and build upon it when you're in practice. You'll be practicing in different countries with different restrictions. We won't talk about America, it makes me upset. Netherlands as well, with some of the healthcare system is very interesting. But unfortunately, as Nick and I know, we're probably heading that way with our private health system if things don't stop soon. So
I can't see me involvement still there, because it's still a lot of our
information doesn't come across. It's not going to make a change. You probably heard this research, but there was a research about medical practitioners, and it said 75% of what you say by a patient is forgotten, and 50% of what's left over is misinterpreted. So you're looking at 25% of what you say having any sort of chance of going through. So you must use techniques, and we've talked with my team about communication techniques and tone and pitch and repetition about how to do that, but that's why it's so important. The second thing which you brought up, which is really important, is about education. As Nick said before, some people just want to have an idea of what's going on. And the great thing about pain science, provided it's not one of those less than 1%ers, which I saw in clinic last week, and my team will tell you, I'm sure Nick does it as well, that we use our language. We don't say, oh, it's definitely this. We never say things like that because the only thing certain in life is death and taxes. That's about it.
Change.
And change.
Change, death and taxes.
I like that one too. Change,
death and taxes.
change,
Certainly of life.
Yeah, so that's really important. But if we can give people an understanding of what's going on, you just see them, and that can really help that because what's happening in their bodies, as Nick said, there's going to be changes through that nervous system. They're going to be in fight and flight. They're going to, I like to use the volume analogy. Like, look, I know it feels like it. The paper cut and the farmer, it might feel like a 7 out of 10, but that's just your perception. We just need you to understand what's going on.
Mm-hmm.
So effective education, I think, was the take-home message. Pamphlets, doesn't matter how we get there. That's really good. Thanks, Fun. Casey, do you have anything to add?
She covered it pretty well. I mean, we definitely talked about like Butler and Moseley a little bit in our courses as well. And we kind of just talked about finding ways to like create analogies and like direct the education for the patient. So like some people are going to be a lot more receptive to education than others, and some people don't really want to hear anything you have to say. And then it's not, you don't want to like trick your patients, but finding ways to kind of incorporate it more into like their daily routine and do things that might not seem like education and treatment, but just like finding ways to fit it into their like mindset on things.
Yeah, absolutely. I mean, analogies are great.
Yeah.
I'd love to hear any of that. Like Nick's already said a few there. I love the Everest one. That was one of the ones I took from the course. I haven't heard that one before, but we need to, on that note, establish our relationship with pain. Is pain necessarily a bad thing? It might not be. It's a protection mechanism. It's helping us. So people come in here, what do they want? They want us to get out of pain. Butler, oh my God, he's just a very eccentric, funny guy. He just had us in stitches, and that's part of the healing. He said, people come in pain. He said, oh, you such a protection. I look at you fighting. I'm so happy. And people are like, what? People come in here wanting to get out of pain, and we need to flick the switch on that. I challenge you guys to do that. I've noticed, particularly since you've come here, because we've shared similar philosophies, and I think my team have now as well. We don't avoid the pain question, but we don't focus on it. What should we be focusing on the consult, as Nick said before?
Function.
Movement. Goal setting. Getting back to what's doing.
Even with our initial assessment, I tried to instill on these guys here that when they sit down, they don't say, well, nice talk. We say, well, first thing you said was, where's your pain?
Yeah.
Now I say, where's your problem? And what is your problem? What's the problem? What's the issue you're coming here for?
Yeah.
And just not, we use the word pain to start with.
Yeah.
And then map out whatever the symptoms might be. But then once we've done all that, we can identify a pattern. And we're trying to, I call it pattern recognition.
Love it. Yeah.
Upslip or downslip.
Yeah.
It's upslip, downslip as a primary driver, and we can recognise all that from there.
Yeah. And understanding why we use that as a primary driver and where we go from there. Do you have anything else to add on that?
The only thing is that with our education, I have education manuals. I've got extracts from books that the girls and teams used, and pictures of Diane Webb's cross bracing effect with the lats and glutes muscles, the nervous system, the tethering points, the various pain patterns and stuff like that. So we show them bits and pieces on that, and then at the end of it, we've got some coloured bits of paper. And the first thing is we have the big words. I had a patient who was so focused on her damage that I ended up doing this out of frustration to get this patient right. And I went down, typed up dysfunction, not damage, blew it up in big 70 font, and gave her a copy, stuck it on the fridge at home. And stick it on your fridge and read it every day. So you got dysfunction, not damage, because she was so focused on damage. Yeah. And then that helped her. But then I started, now I'm using that on a big orange sheet, dysfunction, not damage, so that's orange. Then the green one is motion, not is lotion, which is Butler's terminology. And then I had, if symptoms flare up, don't stress, just stretch. And then I've had another one just recently. It's called a little bit each day keeps it at bay.
Oh,
and
I can't wait to use all these.
It's
freaking
Write
good.
them up.
No, it's already recorded them. It's good. We'll get them.
Hashtag for you, McLean.
Yeah. And there's your walk and talk
all
for
these,
4 weeks.
all these are A4
Physio
sheets
theme.
in different colours in plastic sleeves, and the different colours are highlights, and that visual at the end. And I've got a sheet made up with all those, except for that at bay one, which I can also hand out to once I think really need it, and take it home and put it on your fridge. And just to remind you, they want to keep catastrophizing and keep thinking, and of course it's that paradigm of damage, give it a pill, I've got a torn tendon, I've got a torn muscle, I've got a pulled ligament. No, you've got dysfunction. Because if it's a really inflamed tendon, then what did we do? Shouldn't change that in 10 minutes, which it does change in 10 minutes. When it doesn't change in 10 minutes, then you talk about pathology. But if you can get them to take those take-home issues and get them in their heads, and keep it simple. And that David Butler sort of had that rhyming thing, and that motion is lotion. Said, "Well,
He loves
the
it.
other ones."
Make the knee glisten and gleam, he said.
So now we've got sort of all the phrases which the patients can take away, and then a little bit of stay keeps it at bay, and try and space it out, and it's getting
I'm
them
using
help
that tomorrow.
help
That's
them with
great.
it. The other thing I do with some of my chronic patients who, other patients who come back a bit, probably too much. Well, it's nice to come back and pay me money, but we were very quiet there yesterday, so I might be going broke soon. I don't know, doing so well.
Sorry, we're very quiet in here. It's just the profession right now. Don't worry about it. I've been talking to a few of my colleagues.
Yeah, it's kind of
I don't know what it is.
No, it's just the time of year.
Yeah.
Anyway, they'll come in and I'll come back and I'll say, "You've been doing your stretches." "Oh no, I'm not really doing the stretches. I'm not doing much." I say self-management strategies. "No, I'm not doing them because I'm too busy. I just don't want to do what happened." So I'll say, "Right, we're going to do one more little exercise. So give me your hands, both hands.
I know it is.
Exercises, $98. Exercises, $98. That's what I charge on a session, another session. So I get them to practice that a few times.
And do that. Does that
Go
matter?
out, walking like that. Stretches, $98. I don't really care. And usually, hopefully, as I'm doing this, there's about 2 or 3 other beds running with the students in the other rooms, and the place is really busy. I'm saying I'm scratching the business around here, and try and drive the point home.
Yeah, nice. He's got honest, don't you?
I know, but some of them, you'll say, "I want you to do 5 of these," and I'll go and do 50 because I want to get back quicker. So I'm just going to slow them down a little bit too, and put the brakes on a bit, stop them getting out of control. But by and large, as long as you're with our population, well, they're a lot more chronic. A lot of our population are more upper socioeconomic, and they're paying for themselves, so they're out of pocket. So they've got that fiscal incentive to do it as well. So of course they're paying, but the stuff we're talking about may not work as well if you're having a patient who's coming in under, say, workers' comp or Veterans Affairs, where there's a third party paying. So they're not paying the bill.
Insurance companies.
If they're not paying the bill, then they may not be or won't be as compliant. Some will, but by and large, my experience is that the majority will not be, because they'll have a secondary gain out of having work paid them or having been off work or whatever. The other population that this can run into problems with is where you have even though there could be a private patient, but if you've got a certain family dynamics where the wife is now getting her husband's attention for the first time in possibly years, and while he's looking after and doting on her, or she's in pain, and she gets out of pain, he ignores her again. I've seen that happen with various couples and situations where the one family member uses it as a crutch or as a manipulative tool to keep the other family supporting and looking after them or something like that. So if that dynamic, you have to just pick up, be careful that you just have to, first of all, be able to identify it. You're not going to be able to rectify it because your physio's not a psychologist, but it becomes a persistent issue in the failure to adopt these, then you may need to either write back to the GP or have a chat to the GP, or just suggest they maybe get some counselling or some other form of help to try and get them out of that cycle. But obviously there's something going on or some sort of help in that situation. Some people, of course, if the secondary gain's too much or too great, there's no way you'll convince them either way. So that's going to be something that you need to first of all recognise and be prepared to work around or avoid, or just steer clear, or just say, "Look, nothing further we can do for you."
So what Nick said is, you've got to pick your patient as well. It's very important. There's nothing worse than just banging that head, against one. You've got to know their motivation as well. So like you said, we do have more of a sporty population, although right now we don't, because footy season's over, so we're getting a lot of interesting people here, which is great. But particularly if you're dealing with Nick's clientele, which is largely a chronic pain clientele, you've got to look at their motivations and what they want to do, and think about how you can get your message across to help them. I think is so important. Almost trick them. I trick my clients all the time. I don't do exercise. Oh, okay, cool. I'll just put a heat pack on you and we're going to do some deep breathing. Oh, with that deep breathing, do you mind if you just shrug your shoulders back? Oh, we'll just put you, so we're using just stuff like that. I'm very cheeky like that. And most of my clients get me, which is pretty cool. But don't forget about that. That's pretty cool. Are there any other things in the book that you wanted to go over?
I think basically, if you haven't read it, should read it, and if you've got a copy of that download, we gave the updated copy through. Have you finished with that copy yet? I got the feedback, didn't I? I got it back. Because in that too, there's a thing that Tasha Connon did last year from Columbia University, which goes through the whole system, explains it all, all the reference.
Let's have a look for that.
Yeah.
It's in the student in services. It's in the student in services section, and it's a PDF file, and it's about 30 pages.
Okay.
And it's also referenced. It's got pictures and everything. The whole thing goes through the whole lot, pelvic thoracic,
It's called Tasha Go.
and goes through the Columbia.
Columbia,
University.
oh,
Yeah,
cool.
she did a really good job of it. And if you go onto her website thing, she has the further stuff on it as well. But basically, yeah, she's the first one to really put it all together for me and just
Nice.
really go through. And I think you found it very helpful, and you've gone through it. Yeah, putting it all together. It's much better to teach.
Just put it here, but I think what we also need to be is not be read it for our own points of view. Today I just wanted to have a bit of a snapshot, get some practical ideas, and we're going to go around the room and talk to you about maybe. I've seen a heap of other people, so they're already in there going.
Next one.
Next one.
Yeah.
Yeah.
I'll just share a story with you. I had a patient. Now I'd been treating a whole lot of these Irish people, the community around Coogee, and through word of mouth sort of contacts have got me, and so I treated about 4 or 5 of this group of friends and family. And anyway, one of the guy's partner was an actress, and she'd had like 20 years of migraines issues, and she'd been on some of our prominent TV shows back in the day, Country Practice, All Saints, nursing, the popular sort of series on the prime time free-to-air TV. And she turned up for treatment. She said, "Look, I'm sort of here under suffering." So I said, "What's the issue?" She said, "Look, I've seen all these people. I've spent tens of thousands of dollars. I'm really, you're just another clinician. I'm only here because of my partner and all my friends have just pushed me into coming. That's why I'm here." I said, "Okay, fine." So I just went through and did my assessment. Just went through where was the problem? Let's do this, blah blah. History, all this sort of stuff, and then I said, right. So I sort of sat down and said, "Now listen, from what I've worked out so far, before we start doing it with you, is that this and this has caused your pelvis to do this. As your pelvis is locked out, your rib cage is locked up. As that's locked up, it's putting a Chinese burn through your head." And she looked at me. She said, "I haven't described to you what I'm feeling up there, but you're describing exactly what I'm feeling." And straight away, the light bulb came on. And then she sort of let the guard down, and I think I only saw her 3 times, put the whole thing to bed. So just by unlocking it. So that's, before I just kept on jumping and touching, I just accepted that because I understand that, I appreciate what you're saying, because I know, yes, I know a lot of people like you, yes, I had that, but just give me a chance, just at least to see if we can sort this out for you, and went through just my standard assessment, mental assessment, did all that stuff, and then before I touched her, went through that little conversation, and that sort of helped. Then once I could describe the situation to her, then she sort of went bang. And so if you can work out in advance what's happening from the assessment, describe it in those terms before you go jumping on them and measuring them, and what's most likely happening, then they can sort of see that, no one's ever looked at that before. Particularly when the problem's up here, and I'm the first one to talk about moving down here, and no one's looked below here.
I can't tell you.